Ellie's gonna admit people as they cycle in. I want to introduce myself. My name is John Crocker. I'm the Director of School Mental Health and Behavioral Services for Methuen Public Schools and the founder and director of the Massachusetts School Mental Health Consortium. I am presenting today as part of Thriving Minds, which is an opportunity that MASMHC, the Rennie Center, and the BRYT program have taken on to, in partnership with the Department of Elementary and Secondary Education, to provide some PD coaching around school mental health implementation. So I'm psyched that we get to talk today. If you can be on video, cool. I would love that. I'd love to see some friendly faces. If you cannot be on video, I hope you'll be in the chat a ton. It's going to be bad for your mental health if I'm talking at you for 90 minutes. So let's make this engaging. Let's talk about this topic. Let's get your questions answered. So I kind of want to start with, I talked about this already. Look at all our fun logos. Those are great. Thriving Minds. Okay. In the chat, I would love to see where you're from, what your position is. What do we got? Marlene, no worries. In the chat, Bellingham, social worker, Uxbridge, cool. Westboro, love my friends from Westboro. Oxford. Cool. Lots of different positions, lots of different districts. I love it. I appreciate the engagement in the chat too. Let's get like all 40 people going in the chat. This next one, this next question, I've asked this, I use this statistic a lot in my presentation. So if you already know the answer to this, then just like don't ruin it for everyone else. What is the average amount of time that passes from the onset of a mental health problem to the point at which a kid gets help? What's the average amount of time nationally? Please type that in the chat or come off mute. Get 3,000 points right away if you come off mute and give me an answer. What do we got? Sarah offers 3 months, Tom 4 weeks, 6 months, 2 months, Tracy a year, okay, 6 months, 8 weeks, 6 months. Thanks, Beth. Appreciate that. It's good to see some people I know on here. Friends, what would you say if I told you it's actually 8 to 10 years? What do you think?
Oh my God.
That was perfect. Someone came off mute and was like, "Oh my God." It's horrible, right? Like that is absolutely miserable. 8 to 10 years, average national wait time. Very sad, David. I agree. So at the end of the day, one of the reasons I asked this question at the outset of the screening presentation is that schools are incredibly and uniquely positioned to engage in proactive and preventative identification of kids with needs. We can cut down that wait time. But the sad part is that our mental health system writ large is oftentimes oriented to two things: crisis and diagnosis. We got to get ahead of the problem. We have to put prevention-oriented activities in place. We have to engage in proactive identification of students using screening. So that's why we're here today. I want to give a shout out to Paul. Paul's on the call. He's from BRYT Center, BRYT program. And then I mentioned earlier, Ellie's from Rennie Center. But Paul and Ellie, we work together on Thriving Minds, and it's good to see you in the room, Paul. I appreciate it. So let's keep going. I kind of just said this, yeah? Schools are the prevention arm of the mental health system writ large. We have to lean into that. That is our responsibility. I love our community-based mental health partners, I really do, but they cannot be the solution. They can be part of the solution, but I don't see any other institution other than schools orienting to the need to engage in universal screening. Community-based mental health, they weren't designed to do that. I very much question, I mean, by design, we kind of set them up such that they can't do that. So if we're gonna orient to prevention, if we're gonna orient to proactive preventative services, get to kids early, get to kids before crisis and diagnosis, we gotta own the fact that we are the prevention arm of the mental health system writ large. Make sense so far? You with me? Thumbs up, yes in the chat. Let's see lots of, all right, there we go. Engaged people, I appreciate that. Thanks, Mark. So this is a slide that I've been using to show what we're doing in Methuen as part of our strategic plan for the next 3 years. We feel good about our comprehensive school mental health system, but at the same time, we got to double down on everything that we're doing and ensure that we are reacting appropriately to the needs of our kids. At one of my past presentations, I showed a bell curve and I used it to describe the pandemic. And I think if I had to make a guess, and I'm hoping this is the right guess, we're like right on the downslide. I hope, right? Like, I think everyone's just kind of like, yeah, hopefully we're on the downslide for the pandemic. But you know, that being said, this is not the normal year that I think people were hoping for. I think we've all been reacting to quite a bit of crisis, to quite a bit of dealing with, you know, getting kids into schools wasn't necessarily the whole solution. Definitely part of the solution, but not the whole thing. So right now, all the more important to double down on the services and supports that we offer to kids. We feel that screening is a form of prevention, and we can get ahead of problems, look for emerging concerns, problems when they're small. We do still have to intervene on behalf of kids in crisis, kids with needs that are more intense, that outstrip our tier 1 services and supports. And we need to invest in other prevention-oriented activities too, like social emotional learning. At the end of the day, there's an awful lot of stuff that we have to do, but one of those critical things that we must do is we got to get good at screening. We have to, because if we don't, we're never going to get ahead of problems. We're never going to be able to find kids before crisis and diagnosis. Make sense? You with me? Ed's nodding. I appreciate it. Okay. So let's talk about it. What are we talking about when we say universal mental health screening? We're using a tool or a process that with an entire population. That's the universal part of universal screening. So think like the entire student body. You're going to look for student strengths and needs, and it's often used to identify students at risk for mental health or substance use concern. I'm going to put this right out there right to start. I don't think you can get to universal screening overnight. I think that you can start in on the process, and we're going to talk about slowly building up, bringing to scale the process of screening by starting with really small tests of change. Think 1 kid, 1 measure, 1 day. Anyone engaging in work that looks like this definition right now? Yes or no in the chat? Waiting. Mark, you are cool. Anthony, Allison, that's cool. All right, I love it. So hopefully, for those of you that are engaging in this, I hope that what you gained today is something to maybe further develop your screening program, because it always has to be a process of developing, redeveloping, fine-tuning, honing, augmenting. For those of you who have never engaged in this practice, it's okay. Today, we're going to talk about how to get it off the ground and how to start with 1 kid. All right. When we started in on screening, we had a massive number of questions, lots of things that we didn't know about, questions that we didn't even know to ask. Like, who do we screen? What tools exist? What about consent, staff readiness? How are we going to pay for this? So we're going to talk about all of these things today in some way, shape, or form. And I want to remind people that it's okay to have these questions and to sit in this pocket of innovation. You're not going to know everything at the outset. You're not going to do this perfectly at the outset. It's just not going to happen. Sandy, you offer in the chat, we started pre-COVID and are resuming grade 9 universal mental health screening, craft with grade 10, adding mental health screening grade 10, depending on funding, staffing. Love it. Good times. Sandy brings up a really good point. Everyone's on the hook to engage in screening for substance use using the craft model with at least 2 grade levels. That is a state mandate. So you're already engaged in this work in some way, shape, or form. And I'm going to say soft entry point. Why not add a measure to that process? Another measure to the substance abuse screening process. Food for thought. That's a simple test of change. You could even pilot that with a handful of kids. So Sandy, 1,000 points. Thank you so much. I appreciate it. We're going to get through this stuff too. These are the critical components of universal mental health screening. These are the kind of essential elements that need to be accounted for when you're engaging in this practice. You need a team. That does not have to be a team of entirely mental health folks, but you're going to need a well thought out team that can allocate resources, dedicate time, perhaps allocate funding, maybe not, but certainly a planning team, a team that's going to orient to the logistics of screening. Buy-in from school and community stakeholders. We'll talk about that. PD and technical assistance. We want to make sure our staff are ready for this practice. We don't want to install this without going through the steps to make sure that people are receiving these data well. We want to select the population to screen. We want to select the screening measure, consent procedures, day of planning for screening. What about data collection, analysis, warehousing considerations? Where do we put these data? What do we do with these data? And then perhaps the most important thing, coordinated follow-up to address the needs of identified kids. I'll say this later in the presentation, but I'm going to say it now too. Please don't screen for the sake of screening. It's unethical. You have to respond to these data. This is actionable data that requires follow-up. Cool? Make sense? Who's with me? 60 yeses or 60 no's? That's fine too. Okay. Thank you. I want to make clear that screening is part of a much larger system. A comprehensive school mental health system is defined here. We're talking about a full array of tiered mental health services and supports, inclusive of social emotional learning. This is not a different continuum. It includes a variety of collaborative partnerships. That means we're leveraging our community-based mental health partners to augment but not replace what we do in schools. That's really important because they can help a ton, but prevalence rates that sit in the 30s and 40s, we got to be a part of that solution. And evidence-based services and supports, we have to do that. Okay. I talked about that much larger system. This is some stuff we've done in Methuen that has been done alongside, before, maybe after screening. Group therapy program, lots of teaming, lots of professional development. We implemented a bridge program at the high school using the BRYT model. Yeah, BRYT program, we love it. Get our kids services and supports when they return to school after long-term absence, perhaps psychiatric hospitalization. We're engaging with our families. So lots of stuff that is around screening. Screening is a part of this. Screening adds to our system. And I'll again say, one of the foundational pieces for our system, really critical. I'm going to just give you one example. The group therapy program that we've established in Methuen, without screening, I'm going to say less effective. Why? Because post-screening, we have a group therapy referral window where we can get a critical mass of students, and that referral process allows for us to get multiple groups happening at the same time. Make sense? Cool. You would be so sad if you didn't see a triangle today. I know this about you. Don't worry, I got you covered. So this is a picture of the kind of services and supports that you would see across a tiered system of social emotional mental health, social emotional mental health tiered system of supports. Screening, I'm gonna argue, kind of fits in tier 1. It's its own thing, right? Systems, data, practices. It's one of the data elements in that triad. But I'll also argue that screening is an intervention unto itself, because what we're doing with screening is we're providing an opportunity for a kid who is ready to talk about a problem that they have, that very opportunity. And even if they're not enrolling in services immediately, we are priming them for enrollment in services in the future when they are ready. And we're showing them where to get that help. Very important. Just want to emphasize this. We label interventions, not kids. Kids sometimes require tier 2 services. We don't have tier 2, tier 3 kids. So part of the goal of screening is to find students that require tier 2 and tier 3 services. And also we can use these data to understand the aggregate needs of our kids and develop programming that will orient to those needs. So we're going to go through a couple sets of slides. There are going to be some activities coming up that I'm definitely going to want you to engage in. So just be ready for that. It's going to require you to type a little bit. So we're going to talk about preparation for screening, kind of the stuff that happens before you do the thing. And then we're going to talk about the components of screening that are like the active phase of the screening process. One of the first things you're going to have to do is generate buy-in. And I think it's really important that you consider the ways in which school mental health impacts all the outcomes that people care about, that your stakeholders are gunning for. I guess I'll say this, mental health is good because it's good. I don't need any other reason to argue for more mental health. However, it also mediates outcomes like academics, like behavior, like post-secondary matriculation, all these things that matter a great deal to stakeholders in your community, directly related to school mental health. I would ask for you to consider having an argument for each of your stakeholder groups. It's going to help to generate that buy-in, and also show that this is not something that doesn't fit with all the other initiatives that you undertake. School mental health implementation of screening fits really, really well when we talk about PBIS, when we talk about SEL, when we talk about UDL, when we talk about trauma-informed practices. It is a process of getting ahead of problems. It is a process where we're orienting to prevention. So real quick, we're not going to take much time on this at all, but I would love to hear or see in the chat, how would you justify screening to a group of families and students who don't know about what this practice is? What do you think? Let's do a little group think here. Come off mute, it's okay. No worry, Ann. No worries, Ann. No problem. What do we think?
All right, I'll jump in.
Yeah, Lauren.
I would say it's if you don't do any screening, then you can't. How do you find the kids that you don't know about yet? So there's probably kids in your district that need support, but without screening, it might take a crisis before you can find the ones you don't know about yet.
Fantastic, Melanie. And I saw Lauren come off mute. I thought she was starting to talk. Sorry about that.
No,
Lauren,
that's okay.
Go ahead, Lauren. What do you got?
No, it was pretty similar, just that explaining to families, this is the way that we can catch kids before something happens. And you can give examples of things that have happened that had they had earlier intervention, that they might have gotten some help a little bit sooner.
Fantastic. Yeah, let's get ahead of problems. Let's find problems when they're smaller. Anyone else?
I'll jump in.
Okay.
I might think of it more of, I'm trying to help families. I think about families and community stakeholders, is that they don't necessarily understand what a mental health screening might be, but they do understand a screening at a doctor's or how to screen for prevention of cancer, or things like that. I try to relate it to that. Screening happens all the time. It's part of prevention, public health prevention. It is just part of, we're part of that continuum.
Awesome, Marlene. I love it. Thank you all so much. What about this next question? What would you say to a staff member who's concerned that screening means more IEPs? And in the chat, Paul offers screening will help us to address possible challenges early instead of too late. Awesome. Jacqueline, we want to provide the opportunity to all to be proactive, assessing any concerns, large or small. I love it. What about the second question, though? What do you think? What are you doing, John? Why are you screening? More IEPs for me. What do you think? Go ahead, Lauren.
And I can jump in. It's Lauren. I guess we can say that it'll result in more students getting help, more students able to express themselves, more students able to self-regulate. So it may not necessarily mean more IEPs.
That's right. That's right. Thomas, go ahead.
Yeah, that by doing early identification of students who are at the beginning stages of struggling with mental health issues, we're able to avoid the kind of chronicness of students who are on IEPs.
Fantastic. I love it. All correct, right? Screening. Are we diagnosing when we screen? No, right? Absolutely not. That would be, I would liken that to every kid that failed the math test now has a specific learning disability in math. That's weird. Also not true. This is just a piece of data to help us understand kids' needs more meaningfully. Jacqueline, if that is what it means, then we can support students in a way that maybe gets them on one now, and hopefully improvements are seen quicker. Thank you, Jacqueline. Screening could mean use of better strategies. Love it. Yeah, intervene at tier 1, Allison. Cool. So you get the point. We have to have arguments for screening that we can use with all our stakeholder groups. It's going to be important. So we have to be thoughtful about what pushback we might get, because you'll get pushback, but at the end of the day, the justification for screening far outstrips any pushback that you're going to get. You just got to be prepared for the argument. Cool? All right. I'm going to breeze by this. This is a great, I've linked all kinds of stuff in this presentation. You will get the slides. This is Teen Screen that put together this document with all kinds of justification for why screening is important. Just a good reference tool. I'd like to have it at the ready, but we don't have to get into it too much. When we talk about screening, another aspect of the work that you're going to need to do is needs assessment and resource mapping. What do you have? What do you need? What resources can you draw upon? Do you have staff that are maybe savvy when it comes to data collection and analysis, who are motivated by the expansion of school mental health? Do you have some funding? You know, I'm going to reference fund code 613 again. That's some money directly pointed at universal screening for one of the categories. I think category B, maybe. I don't know, maybe category A. I'm not sure. But it's going to be important that you orient to what do I have and what do I need? Some of the things you'll need, undoubtedly, professional development, resources, staffing. You're going to need that team. You're going to need to know who should be on that team. Do you have policies and practices that you need to develop to actually get screening off the ground? Is there some policy existing in your district that says you can't screen students for mental health problems? Gosh, that would be something you need to navigate, right? So you got to know about these things. I also want to talk about this, because oftentimes when we talk about needs assessment, people are thinking about like, well, it's me, John. Like, I'm at this presentation because I'm the only one that's going to actually like engage in the screening practice in my community. Can I still do this? And my argument is, yeah, you can. You do still need a team, and that team does not, again, have to consist of only mental
Hold
health
it,
staff.
because we gotta go.
That takes us how long to get there?
Thanks, Marlene. But what I will argue is it's the rate at which you get screening off the ground that will change, the speed at which you scale up. Can you screen one kid one day, one measure? You certainly can. Can you screen a class, maybe react to that? Can you screen students who are already enrolled in services? Sure. So it's about engaging in screening thoughtfully at the beginning such that you can get some data and show that to your stakeholders so you can get more help. Okay? Let's keep going. I do want to acknowledge barriers. They exist, of course. You know, what presentation would it be if we didn't talk a little bit about barriers? But I'm going to run through these rather quickly, and I guess I'd ask for you to like brainstorm in the chat if you've got thoughts around how to navigate these barriers. For funding, I want to share that we have spent $0 on screening in Methuen. We use free measures. It's not the case that you have to spend a ton of money on lots of measures. So just throwing that out there. It's time, sure. It's energy. And I guess I'll jump down to time as a barrier. You're going to be saving on time when you are responding to less crisis, when you're getting ahead of problems, when you're able to orient to needs early. Investment in prevention. What about professional development? Friends, you are literally sitting in a PD session on screening. Please continue. Readiness to provide follow-up services. This is a big one for sure. I think, again, it points to, do you have the capacity to screen all, or do you have to start smaller? Screen who you can. Screen such that you hit capacity, but know that that is a piece of the puzzle. Can you provide follow-up services? That requires you to resource map an awful lot and assess needs. Implementation support. Thriving Minds is very happy to engage in implementation support of screening, which is one of the reasons why we're holding this session today. MASMHC talks to districts constantly about screening, so we're happy to be a resource. Sean offers timely collection of data like that. I appreciate that. Okay. Does this make sense to people? These are real barriers, but you can get through them. We good? I want to hit pause. We're like almost half an hour in. Thoughts? You with me? Okay. I'm seeing people nod. I'm seeing some thumbs up. It's like 3:30 Monday before Thanksgiving. You're still alive. I love it. Let's keep going. Staff readiness and teaming. I think one of the reasons I mentioned this is it's going to be incredibly important that you are orienting to staff roles as you roll this out. Who are your people who are going to be providing follow-up services? Do they know that? Who are your people who are going to engage in the practice of screening? Are they going to be comfortable with that? If this is a new practice for your district, I think it's timely to ultimately unpack the various roles and responsibilities of the people who are going to be using these data. And I will say that, there's a whole 2-hour presentation that we give on leveraging school-based mental health staff effectively, and the chaos that sometimes ensues when we are not planning thoughtfully our staffing model. Lauren offers in the chat, hi, I'm from Great Wall Tech. One of the barriers we've identified is the size of the school, 2,400, and finding a screener that is easy, quick to administer, and easy to score online, generate a comprehensive report. We did the DESE last year, which yields great data, but the logistics of setting up was incredibly time consuming. Yeah, for sure. Align screening with SEL standards. You could do that, Sean. Lauren, I'm going to show you a database in a hot minute and I'm also going to show you how to crunch the numbers and get your data. So we'll go through that real soon, Lauren. It's going to be a part of the presentation. So suffice to say, right, know your people, know what they're capable of doing, but also we have to evolve. These roles need to orient to the needs of kids. That's the most important thing. Training programs have changed an awful lot. We're churning out master's level clinicians who can, and in my humble opinion, should be providing evidence-based therapeutic services to kids. And screening is a piece of that. Let's skip that. What is a school mental health team? There are some great resources through the SHAPE system to orient you to kind of building a multidisciplinary team that's going to be able to manage the logistics, the communication, allocating resources, being able to plan accordingly for screening. Again, it doesn't have to just be counseling staff. It certainly should include people who can allocate time and resources. I guess, quick hit, I'd love to see in the chat. These are some features of a quality school mental health team. How many could you check off? Based on what you currently have for a team in your district, how many of these things are you able to check off? That it's a multidisciplinary team, that you've streamlined your teams to avoid duplication, that you've got a meeting structure, that you promote data sharing among team members, working relationships with community mental health. What do you think? Are we at 2 of 5, 3 of 5? Are we hitting all 5? For those of you on video, let's hold up those fingers. How many? 4, okay. Thanks, Mike. 4 out of 5, okay. So just be aware, 3 out of 5. Your team is going to be a massively important component of getting this practice off the ground. If you don't have a school mental health team, you're certainly going to need one to continue engaging in screening, okay? Again, so far, what we've talked about has really been like, what is screening? Some justification for screening. We've talked about really the lead up to screening. This is all pre-screening stuff, generating buy-in, getting a team together, needs assessment, resource mapping, getting the lay of the land, staff readiness. We're going to talk real soon about the components of screening, but these, I don't want to gloss over this. This is incredibly important stuff. If you don't do this stuff well, then you're not going to be able to engage in screening effectively. No worries, Will. I'm glad you're here. The other piece that we need to orient to is this. Who here is familiar with continuous quality improvement practices, plan, do, study, act cycles, stuff like that? Show of hands, yes in the chat. Mike is, cool. Anybody else? A few of you, Jacqueline, okay, cool. So I want to offer this practice as a way to onboard screening safely, effectively, slowly. Plan, do, study, act cycle, PDSA cycle. The idea behind it is that you are defining an objective, questions and predictions, that you are planning for data collection. You're mapping out what this practice is going to look like. You're going to carry out that plan, analyze data relative to implementation, analyze it, study it. How did it go? Did what actually happened match your predictions? What did you learn? What would you change? And then lastly, are you abandoning, adapting, or adopting this practice? And if you're adopting, what does that look like? Are you scaling up? If you're adapting, what are you changing? This is an incredibly important piece of implementation because it allows for you to implement things in a controlled way and in a way that allows for you to ask questions about the implementation before and after. And it looks like this. An iterative cycle of small tests of change that lead to larger tests of change over time. Think micro level, lots of small tests of change, leading to larger changes with a larger sample size when I'm talking about something like screening. Let me give you an example. Think of, and I've said this during this presentation, what if all of you decide tomorrow that you're going to map out a plan to screen one kid using one measure one day? You're just going to try it out with one kid. And then you're going to unpack what you learned as a function of that small test of change. You're going to figure out an awful lot during that small test of change. And we'll go through that in a minute, but that's the kind of micro level change that you want to test out before you jump into this in the deep end. Here's a sample PDSA worksheet for you to map out your work. This just allows for you to reflect on your practice a little bit more explicitly, as opposed to, you know, I've been in the room too, when we're just kind of throwing ideas around. We're like, yeah, let's try the thing. And then we carry out the plan and ultimately something goes sideways, and we could have avoided that poor implementation if we just slowed down a little bit and maybe reduce the size of the change. Why do we keep our tests small at the beginning? Well, we don't want to hit disaster, because when we try to screen too quickly and forget a critical piece of the puzzle, well, it hurts morale, it hurts buy-in, it hurts our momentum. It might hurt kids. So you gotta be careful about how you implement. Mess up when the scale is very small. That way, when you get to the point where you're scaling up, you've accounted for those mess ups. You've accounted for those errors in prediction. Does that make sense to people? You with me? Okay. Let's talk through this. Our team decides that we're going to implement universal screening all at once. We're just going to go with this. We're going to do it the not PDSA way. We're going to screen 1,000 kids using the PHQ-9 tomorrow. Question 9 asks about self-harm, suicide. And you decide, you know what, I can put off the score interpretation and clinical interview training until later. And you're going to put together a list of who will respond to the data after you get through the screening. Let's do the screening first, and they'll figure out how to, follow up with these kids later. What are the potential implications of approaching screening in this manner? Please, in the chat or come off mute. What do you think is going to happen? Come on, friends. I've got legendary wait time. No. Yep, go ahead.
So with number 9, you can definitely miss someone who's suicidal, which would be bad.
There you go, Lauren. Nope. You're not responding to a kid that stood up and said, I need help. And that help includes suicidal ideation. Yep, Sarah, not being able to respond in a timely way. Some kids will need immediate attention. Waiting would be very harmful to them. I love that, Sarah. I appreciate that. Thank you. Someone might slip through, might lead to 51A on you. Fair, Will. Absolutely. Tom, go ahead.
I was just thinking of the screening 1,000 students, let's say 12% kind of pop up with needing immediate assessment. Can you immediately respond to 120 students, providing thorough, where do you get the staff from in order to do that? And how long does it take, given that some of them might be at pretty high risk?
It's a phenomenal point, Tom. The clock starts as soon as you screen. Any student that is endorsing question 9 on this measure requires immediate follow-up, same day. Can you get to 120 kids? Can you get to 200 kids? Post-pandemic, I shouldn't say that, I'm gonna jinx it, right? But numbers during the pandemic are much higher. The prevalence rates are astonishing. In the chat also, I'm seeing some good stuff. There's a kid at risk and data to support it, but we won't get to it until later. Might show the kid that you don't care. That's a really great reflection, Jacqueline. We also need to be prepared to score and have the response for heightened students ready to go. Yeah, agreed. Awesome points. You get the picture, right? Let's start small. Let's mess up when we've got 1, 2 students in the room. That's awkward, right? Messing up screening with 1 kid is uncomfortable. Maybe you score it incorrectly, you administer it wrong, you engage in a practice that isn't perfect, but you know what? That's not career ending. It's uncomfortable. You screen 1,000 students with the PHQ-9 tomorrow and you don't prepare for it, that's something else. Okay. We've talked about this. I don't want to belabor the issue, but look for the easy wins. Think small and then think smaller. What about a kid who's already receiving services, so that when you screen in the student, inevitably, you're not adding to your roster of students that you have to ultimately provide services to. You're just practicing screening with a kid that you already serve. What about looking for a family that just loves you? They're like, you can do no wrong, Mary. All right, like, please, whatever you want to do, you want to expand your practice. I love it. Try it out on my kid who you're already providing services to. Okay, that makes sense. You're just getting good at screening. You're accounting for those components of screening so you can do it well. So I mentioned this, when we first started screening, we were really rapidly testing at the micro level, where we were identifying areas to improve, establishing systems to make it a sustainable practice, and scaling up only when we felt good about what we were doing with a small set number of students. It's really that ad hoc screening. It improved our confidence in the practice. It allowed for us to reflect on the practice in a really controlled way. What can you learn by screening a single student? You're going to unpack the whole mess of screening, soup to nuts. You're going to learn about consent. You're going to learn about selection of measure. You're going to learn about how to actually score the measure. how to use the data. It's going to bring up questions around, well, should I do this? Should I use this tool or that tool? What if I administered it with me not in the room next time? So you learn an awful lot about screening by screening one kid. You don't have to screen 1,000 students to unpack these questions. So I would encourage you, start small and then scale up when you're confident of the change that you can make. This is another critical piece, the lead up to screening, selection of a population. You can take a look at your aggregate data, look at YRBS, look at vocal, look at any of your community-based needs assessments, so you can figure out like what should we actually screen for and who should we screen. Maybe transition points, grade 8 to 9, grade 4 to 5, a population in your district that you're especially concerned about based on community-based needs assessments. Really ask yourself, what's the intention behind our decision to screen this specific population? I'm also going to share with you lessons learned over the past 8 years and something that you already know. I'm fairly certain that if I threw darts at a map, I would be able to say that district has a problem with anxiety, depression, and post-traumatic stress. So when we're talking about selection of measure, let's cut out the middleman and know that like we have problems that we already are aware of. Let's orient to those problems and not spend a tremendous amount of time trying to figure out like, what are we going to screen for? It's pretty obvious right now what our kids are dealing with. And if we start to screen for those things that are very obvious, it's going to allow for us to move a little faster. This is incredibly important, my friends. Please, when you're building out your roster of students to screen and to pilot screening, you really need to have equity drive that selection process. The population that you're going to screen to start needs to reflect your population writ large. You need to be inclusive. You need to ensure that the sample of students is a reflection of your population and that we're not disproportionately selecting students who can easily engage in the process or for whom like they're just close at hand. You need to just bear in mind that including your full set population in that sample is going to allow for you to account for some other questions relative to screening, like, is this measure culturally sensitive? Do I have to account for screening in multiple languages? Am I screening for the right kinds of issues? Or have I selected a sample of my population that is disproportionately one way or the other? So I would really encourage you to bear this in mind as you start to plot out how you're going to screen. It has to be the case that you're driving at this with equity in mind. Okay, we're just at the halfway mark, and that's okay. I've got like 65 minutes worth of stuff left. I want to kind of like put to rest that lead up to screening conversation, the continuous quality improvement piece, like really thinking about thoughtfully engaging in this practice. Now let's talk about the components of screening, the actual things that drive screening. Selection of measures. We got to ask these questions, right? Where are the tools? How can we account for funding barriers? How can we find an efficient measure that produces actionable data? I heard Lauren talk about wanting to find a tool that was easy to score, finding a tool that was going to be simple to use. There are all kinds of different measures, pro-social competency-based measures versus symptom-specific. You got to look at it as a continuum. We do look at symptom-specific, but we should also look at asset-based tools. I think that's important too. Using multiple tools to look at this going down while this goes up, that's good too. Okay, quick demo time. Who has a shape system account? Quick show of hands. Lauren does, Mary, Mike, Melanie. For those of you that don't, I want you to take a peek at this. You can see the shape system on my screen right now. Yeah, you're good. Okay. when you're asking yourself like, well, where do I find all these lovely measures, John? I don't even know where to look. Screening and assessment library and SHAPE is going to allow for you to move quick on this. Let's pretend like you're looking for a measure for anxiety that is for screening. It's for a 12-year-old. It has to be in Spanish. The student's going to report it out. It needs to be free. Well, there you go. There's a bunch of different measures for you to peek at. This is an incredible tool to be able to get at free measures. And then once you do that, you can click in and you're going to get all kinds of information, including access to the measure, what languages it's offered in, some sample items. You'll understand how to score it, the benchmarks around the different subscales, how to handle scoring, how to handle interpretations, all there. It's all just linked in there. It's all free. Does that make sense to people? Did you know about this? Is this a tool that you're ultimately planning on using now in the future? Give me a quick show of hands, thumbs up. Yeah, we like this. I like that you like this. I'm gonna put it in the chat. theshapesystem.com. That easy. Would it take me 10 seconds to find a measure that would match my needs? Done. Okay, let's keep going. Andrea, you'll be able to access the recording, no worries. It'll be sent out to you, okay? Thanks for being here. I was gonna have you do a screening measure scavenger hunt, but I wanna make sure that we have time for me to demo screening for you. What you just saw was the GAD-7, and I was gonna have you look at the PHQ-9. Ultimately, my point with this activity is that that info sheet is going to give you a lot of info, a lot. It's going to help you to be really confident about how to use that measure. It's not the case that there's some other thing that you have to orient to or that you have to account for. It's all right there. So whatever measure you end up selecting in the SHAPE system, you're going to have some quality info on how to implement it effectively. Anthony, question on SHAPE. Does your school district data get posted publicly? You can click a quick button, Anthony, and the answer is no. You can, and by publicly, I mean people who, like the National Center for School Mental Health can see it, but it's for research purposes. So no, you can turn it off. No big deal, Anthony. I'm gonna argue that using a problem-specific screening tool is something that we've had a lot of success with, and that I would argue is a way to get to student needs and produce a really rich data set. I mentioned this, you know, we took a lot of time to try and land on the right measure. We looked at our counseling logs for like 2 years. And what did we find? Anxiety, depression, and trauma were the things that we should be screening for. So like, I just offer that as food for thought. Let's not make this process harder than it has to be. We know what our kids are up against right now. So let's orient to that. Let's screen for that. The other piece that I think is important is that when we look at these screening tools, sometimes, you know, there are some global measures that will point at a student and say, this student is at risk. And I guess in that situation, my follow-up question is, well, at risk for what? It almost requires a secondary screen to get at the specific issues that we're going to try to address. So I have no problem with global screening tools, but what we have tried to do in Methuen is use lots of symptom-specific measures. So like GAD-7 for anxiety, PHQ-9 for depression, UCLA brief COVID-19 trauma screen for post-traumatic stress, and look at all that data side by side. It's a really rich data set and a comprehensive view of what students need. So that's my rationale for using a problem-specific screener. But I would argue that, you know, screen for what you need. Screen, you know, you are going to undertake action after screening. So please make sure that whatever action that is has the appropriately matched screening tool. If you're looking to improve your social emotional learning curriculum, well, you should probably look at a tool that looks at social emotional competence. If you're looking to find kids with anxiety, depression, and trauma, you should probably look at a symptom-specific tool. Cool? Yes in the chat? Karen, can you list the specific screeners? I'm going to get to that, Karen. It's embedded in the presentation for sure. Okay. Here are a couple of measures that we use a lot. PHQ-9, GAD-7. These are simple to score. These are easy to use, reliable, valid. I offer these, they're free. You've probably taken the PHQ-9 at your primary care office. It's used there constantly. But you know, it can be this easy. And Lauren, to your point, like quick hit, easy measure, shape system. Check it out. You know, look for those measures that are going to be shorter in length. These two, they work. They're just good. You will have to establish prior to, and now we're getting into the weeds with selection of measure, cut scores and decision rules. You're going to want to establish the score ranges that you'll respond to. I will argue that moderate to severe is what you should be looking at responding to. And 100%, any question that asks about suicidal ideation, self-harm, yeah, for sure, responding to that. Even if a student scores in the mild range, you should be responding to a question of suicidal ideation or self-harm. They're not online, so no easy way to track data or create anything aggregate. Well, Lauren, I'm going to show you how to do that today. Good times. Determining the indicators for referring students, that's a big one too. We want to account for risk factors. We want to account for like, why are we going to refer the student? Oh, of course, no worries, Lauren. And then, you know, establishing some crisis protocols. You know, prior to screening, you're going to want to know, is your team ready for suicide risk assessment? Does your team have written procedures for referring students for an evaluation? For 51A, definitely a prerequisite. You're responding to these data to take action. Okay. What about consent? What options do we have? What's the difference between active and passive consent? I guess I'll describe it like this. Active consent, can I do the thing? Passive consent, I'm gonna do the thing, tell me not to. We have adopted passive consent with opt-out procedures for a number of different reasons. One of those reasons is it allows for us to orient to the needs of kids way more efficiently. But of equal importance, we want to send a message that all the things that we screen for, vision, hearing, dental, all those physical related things, mental health is just as important. And ultimately, the number of families that opted out, I always ask this and I'm disappointed because people guess it right away, but I'm gonna ask it again. What percentage of families opted out of screening when we first started this? What do you think? Type in the chat, come off mute, what do you got? 3%, Mike? Or 3, okay. 10, less than 5%. See, I continue to be disappointed with asking this question. Less than 1%, less than 1% opt out. It's not a thing that people are doing. So it is something that, you know, it's either the case that parents are super on board with screening or they are apathetic about it enough that they're not opting their kids out. And I'll take either way. Here's our passive consent message. This is read multiple times throughout the year. A version of this is also read in real time, right before screening. We don't care if kids opt out of screening, that's okay. The goal of screening is not to get 100% of kids to screen in or to participate. It's to provide an opportunity for kids who are ready to talk about a problem, that very opportunity in a safe, controlled way. That's all. And if we look at it like that, then we don't have to be worried so much about those who choose not to participate. It's okay. 5 opted out, Ross. Yeah, it's nothing. I know about your screening, Ross. It's good stuff. Love it. We want to make this a sustainable practice. In the beginning, I think I shared with you that, you know, we were engaging in screening passive consent messages, gender inclusive, 100%, Amara, 100%. This is old language too, so I appreciate you calling that out. We have to make it gender inclusive. Typically, we say students when we're talking about messages like this. So, good call, Amara. In the beginning, we were using paper and pencil, right? Ad hoc screening, active consent, because that's all we knew how to do. We were also moving from, we were also administering screening kind of just in the counseling office. So in order to make this a sustainable practice, and as we move through that iterative process of PDSAs, so small tests of change leading to larger tests of change, we were able to check our practice and say, you know what, moving from 25 kids to 300, that's requiring us to take a hard look at consent. Or that is putting us in a position where, to Lauren's point, I can't do the paper pencil thing anymore. It's way too hard. So as we evolved, we adapted our practice. We made changes to our practice. We started with the pile on the left, and we got to a point where we now use Google to score the data for us, to organize the data, to keep the data at the ready, to allow for immediate follow-up. This is the evolution of our practice over time. Active consent to passive consent with opt-out as our population grew. Paper and pencil to web-based screening. Single student ad hoc, small group, grade level, school-wide, district-wide. And then administration facilitated by school mental health staff to ultimately using the advisory course or the health course or the tech course, so that we could leverage the entire staff and we could have our mental health staff waiting in the wings receiving the data in real time. Let's get this. This is the most important part of screening. You have to follow up with students. You have to engage in ultimately a clinical interview. You are interviewing students such that you are gathering information about the validity of the problem that we found in the screening data. It is going to be the case that some students rip down the right side of the tool and they thought you were never going to follow up with them. You call them down to the office, they're like, oh man, I'm good. Sorry, I didn't know you were going to call me down. I was just messing around. Okay, no problem. Just please don't do that next time we use this to orient to student need. Thank you. But it's also the case that we can't make referrals, we can't make decisions based on screening data alone. You got to scrub the data. What did you learn by screening? Follow up the student, ask questions. What kind of questions? Things like, is this a problem for you consistently? Are you just having a bad day, or is this a problem that has lasted for quite some time? Do you want help around this problem? Does this impact your life in any way? Do you have a support network at home? Are you already receiving services? You know, this is going to paint a picture of need such that you can make an informed decision about whether or not you're going to follow up with the student and make a referral. And by make a referral, I don't mean refer and hope. I mean, make a referral internally, make a referral maybe to a community-based mental health agency in addition to your internal services. This is the gold standard. 100% of students who require follow-up receive it within 7 days. Any degree of self-harm or suicidal ideation endorsed, same-day follow-up. We did put crisis teams on call when we were engaging in screening for the first time. We had no idea who we needed to follow up with, or how many we were going to have to follow up with. We ultimately didn't need these crisis teams, and that felt really good. However, it was a nice warm blanket to have them waiting in the wings in case we had to make a ton of referrals. We've supported our screening efforts with community-based partners by making sure that they are aware of the fact that we're going to be engaging in screening, and for our emergency service providers that they might be getting more referrals on that specific day. But we also have bolstered partnerships to allow for more services to take place. And this is especially important when we go back to the barriers. If you don't have internal capacity to provide services yet, please build that capacity. But in the interim, leverage your community-based partners to be able to refer post-screening so that you at least have that. Let me pause, because I've been doing a lot of talking. Are you with me still? It is 4 o'clock. We've got 30 minutes left, friends. Let me see some yeses in the chat. Are you with me? Still good? Okay, lots of yeses. I appreciate that. Cool. Let's keep going. Friends, let's screen. We're gonna do this. I'm gonna drop in the chat a link. And this link is to the PHQ-9 that I ask that you please fill out with fake answers, okay? I do not want to do a coordinated follow-up the Monday before Thanksgiving. I also don't know where any of you live, except for Mike. Oh, Mike, I don't know where you live. All right, please fill this out. What I'm going to do is I want to show you what happens with these data. I ran this back on August 3rd with a different group. So there's already some data in there, but I want to see your data roll in real time. We'll use this as the data set that we're going to orient to, okay? This is day of screening. We just read the passive consent with opt-out procedures. Students are currently filling out the measure. Your school mental health team is waiting in the wings. We are sitting around a screen waiting for this data to come in. People are filling it out. Beth is the first on the board. See it? Go quick with this so we can just get to the data. You don't have to be accurate. Here it comes. Data rolling in real time. Now imagine these are kids, right? Imagine these are kids that you're going to orient to in less than 20 minutes. We're going to start calling down our friends soon. Look at it all roll in. It's exciting. Now, in order to make this data efficient, effective, Lauren approved, we are going to need to do some stuff to this data, right? So what I want to show you, and people are going to still put answers in, but I made this hard on myself. I could have put numbers in. Instead, I put the narrative response. So I'm just going to control F it, and I'm going to find in sheet. And what am I going to find? Not at all is going to be 0. Replace all. More than half the days. I know that that's a 2. Replace all. Nearly every day. Well, I know that's a 3. Replace all. Several days. That's a 1. Bam. So now I've got some nice, pretty quantitative data, but I'm not done because I got to drop a formula in here because I don't want to hand score all this stuff. So what I'm ultimately going to do is I'm going to drop in this very simple formula, which is equals sum of, and we're going to look at G2 all the way over to O2. There we go. Someone's having a bad day. Perfect score on the PHQ-9. If you can remember that simple formula, you can do this. I also created a video that unpacks this at a much slower pace and is very methodical. I've linked it at the end of this presentation, but I want to show it to you in real time. So great, I got 1. Do I have to do that a bunch of times? No, man, just like double click on the cute little box at the bottom. I've just scored 130-ish measures. Maybe took 2 minutes. Let's take it one step further. Let's throw a filter in here because my team's like, you kidding me, man? Like you want me to go line by line? No, that's all right. I'll take care of it for you. I got you. Z to A. I know the cut score for the PHQ-9 is a 20. All right. These kids are getting follow-up. All these kids. Not only that, but these kids are getting a follow-up too. Tell me why. Come on.
It's the it's a suicidal ideation question, correct?
There you go, Mike. Melanie, you were going to say the same thing. I know it.
Same thing, self-harm, yeah.
There you go. What happens if I don't account for that? And I think I'm probably using the, I don't have the cut scores memorized for this one. I think maybe these two kids would have, I think it's 10 to 14, 15 to 19, 20 above, something like that. But let's pretend like this student's not getting follow-up, these two, right? If we're responding only to moderate and severe, these two kids don't get follow-up. However, they endorse question 9 at a 3. they're thinking of suicide and self-harm a lot. Make sense? That's why we have a two-stage follow-up with this. No worries, Sandy. I have to provide a consult to a college. Thanks, Will. Seems like aggregating all this data is relying on closing out the survey. How long do you factor in for students that miss the original date and need to make up, factoring in that the clock starts as soon as the first wave is completed? This, Chris, we typically keep it open for 24 hours. And by that point, after 8 years of screening, I can tell you that closing it out at that point has yielded great success. That is not but it's also not the case that that's the end of the conversation for that student. We screen multiple times a year, so it allows for us to get to those students that maybe weren't ready to participate, or they were. We do call kids down who were absent as well, Chris. So it's a good point. I think we do have to ultimately shut down the survey so the screening window is closed. But we do so in a way that's sensitive to the fact that kids are going to be absent, or kids might need a hot minute before they engage in screening. So really awesome question, Chris. Appreciate that. Ross says you can map the data to a separate tab with all the students listed ahead of time and formulas preloaded. Yeah, Ross, you absolutely can. That's what we do too. I wanted to make this real hard. I wanted to make this labor intensive such that it didn't auto score, that it didn't produce quantitative data to start. This is worst case scenario, and we just got through it in 3 minutes. No worries, Beth. You have a good one, okay? I'll see you soon. Does this make sense to people? Is this rocket science? No. The hardest part about what I just did was throwing a formula in there. It's a very simple formula. You can do this. So Lauren, we have moved from screening, hand screening, right, to use of a reliable tool in Google that produces data that we can access quickly and move on. Done. Okay, where am I at? 52. We're in good shape for time. Friends, I'm in the dark in my office. I don't know if you noticed this. Give me 2 seconds so I can go turn on my light. That'd be cool. So I'll be right back. All right, I'm back. I couldn't even see the keyboard. Okay, we've live demoed screening. You took part in this. How did it feel to screen as though you were a student? I asked that because I think it's really important for you to reflect on kind of the student experience with screening, and it's not necessarily one that's familiar to them. So one of the things that we did once we got into screening a little bit was we realized that we needed an FAQ page to really unpack screening for kids. And we actually did a lesson on why do we screen and drop that into advisory just before our depression and anxiety screening. That yielded really good results. So just bear that in mind. You might have gone through this process and you were like, geez, if I was a kid, what would that feel like? I think it's a worthy question and something to definitely orient to. Okay, let's keep going. I want to share a little bit of how our implementation went once we got beyond that ad hoc screening. We started in on use of the GAD-7 and the PHQ-9. Those were our first large-scale tests of change. We were piloting at the grammar schools with RCADS, another measure. This is our first data set from our first large-scale test of change. About 22% of the students that engaged in screening scored in the moderate to severe range for anxiety. I was expecting that we were maybe going to get 15 to 20% of students participating in screening. I was pumped to see 45%. That number has only increased over time. Why? Because now this is a familiar practice for students. We've reduced the stigma associated with engaging in screening, and now it's just something that people do. It's not a big deal. It's another conversation. Similar results for depression. We use the PHQ-9. About 22% of students scored in the moderate to severe range. And you can see that it was about the same response rate. We scaled up in the following year, looking at adding the strengths and difficulties questionnaire to use as a global scale. I like some of the subscales in there. We started in on craft, grades 7 and 9, and then we scaled up RCAD screening. I guess the thing that I want to share with you is that, like, once you have success with one kid, then replicating that with 5 becomes really easy. And once you have success with 5, replicating that with a class, that's pretty easy. You figured it out. Replicating with a grade level isn't going to be bad after you found success with a class. And using different measures in different grade levels for different reasons is going to become easier and easier. Once you get this practice nailed down, you can engage in this practice in a lot of different ways with a lot of different populations, because you will have figured out the essential components of screening, things like consent, selection of measure, coordinated follow-up. What do we do when a crisis occurs? Once you check off those boxes and you feel good about it, you can move pretty fast bringing this to scale. I think it's also important that we orient to the fact that this is not just a high school problem. We screen kids in, actually, as of this week, we're a K-12 screening district. We feel good about it. And in grades 5 through 8, we saw about 13.36% of students scoring in the moderate to severe range for anxiety or depression. So this tells me that this is a problem that starts way earlier. And if we wait until high school to screen, then we are not engaging in the kind of prevention work that we could be. Because what's going to happen to that 13.36%? It's going to march on up to 21, 22%. And we could have done something about it 4 or 5 years in advance. Remember that statistic, 8 to 10 years, typical wait time. Why? One of the reasons behind that why is no screening happening. This is what we screen for in Methuen, and this is actually outdated, as I stated, because this does not include K2 screening, which we're now doing. I want to give you a sense of the kinds of measures that we have on the table, what we're screening for. We're screening not only for symptom-specific issues, but for social emotional competence. We're part of the CELIS project, which the state is running to really pilot use of a pro-social measure that looks at social emotional competence and student self-report data. But you can see that, you know, what we screen for is awfully broad, but you can imagine the data set for each of our kids. It really paints a clear picture of need, and that we wouldn't be able to get if we were simply using a global scale. Does that make sense? Good. Okay. Here's our breaking news. This is why I don't have K2 screening on there on that previous slide, because this just happened. We're actually using closed gap K4. Closed gap is a student self-report measure that asks really, really developmentally appropriate questions of kids in a way that allows for us to capture that screening data from our youngest students. You know, we're talking about general mood is what we're capturing, and high frequency. So I think that's the best we can get when we talk about screening our youngest kids, because ultimately I'm not going to pop GAD-7 in front of a kindergartner and expect good results. But this is a developmentally appropriate and actually designed for elementary tool. There are some follow-up questions that get asked. It gives you a really clear sense of, like this is on the dashboard. It will show you kids that urgently need help because they can ask to speak to an adult after they've completed this quote unquote check-in is what they call it. Some students are going to report, you know, they report out on their needs, their emotion, their energy level, they are engaged in an activity, and then they're asked to report out, do you feel better, worse, same? This all gets done in like 3 minutes, super easy. It is quick, it is simple to use. It allows for us to orient to kids' needs before a problem happens. And you can aggregate the data as well. And you can take a peek at across your population, how many of your K4 kids are reporting that they're sad or that they're tired or that they're frustrated? How many of your kids are reporting that they have low energy? These are follow-up questions that are asked as well. If a kid reports a negative emotion, then they're asked, well, did you eat anything? Are you hurt or sick? Are you having problems at home? Peer issues? Did you sleep well last night? So I want to paint a picture for you. Imagine a kid that says, I'm sad and I have low energy and I have some problems at home and I'm hungry right now and I didn't sleep well last night. I didn't eat this morning. That kid is a time bomb in 4 hours, right? That is a kid who's going to be dysregulated for sure by 2 o'clock. This allows for us to get ahead of that problem. This allows for us to find that kid early and provide the care that they are asking for and that they're pointing out. Make sense? This is a crisis resolver. This is prevention. One of the obvious reasons to engage in screening is that it helps us find students, and a lot of them. Once we started screening, we compared the pre-screening data to the post-screening data, and we were able to identify that 63%, we had a 63% increase in students who were eligible for services for internalizing concerns. So it tells me a couple things. We had other identification methods that were working. Student self-referral, parent referral, staff referral, but we were missing a huge swath of the population absent of screening. So this practice is essential if we're going to find students with internalizing concerns, especially because as a field, we're pretty terrible at identifying students with internalizing concerns. We're just not good at it. And that's not your fault. It's no one's fault. It's just hard to find. So we need a process like screening to help us with it. I talked about this, group referral, immediately following the screening window. Get your critical mass of students so that you can engage in group well. I often hear, well, like Melanie's got a kid, but next week Nicole has a kid that would be a good fit for group, and Paul's got 2, but one of them's enrolling in individual services. Like, it's a nightmare putting a group together. But if you do it immediately following screening, you're good to go. I'm really proud of these data. This is our 5-year anxiety screening comparison data. This is prevention in action. This is pre-pandemic, obviously, but we saw an 8.5% decrease in student scoring in the moderate to severe range for anxiety, and an 11.5% increase in students reporting no concern. I'll take that all day long. This data goes straight to our stakeholders. This is the impact we have on kids when we orient to prevention-related activities. Similar trend for depression. We see decreases in severe and moderate. We see increases in no concern. Why? We screen early. We provide proactive preventative services. We don't wait for crisis and diagnosis. And we send the message that mental health is for all kids, not just students on 504s and IEPs. We service general ed students all the time. This is the sad reality that we're up against now, friends. About 61% of screened students at Methuen High School during the pandemic reported moderate to severe depression, anxiety, or post-traumatic stress. 42% reported severe on one of those measures, and the kicker, 17%. Severe, all 3 measures. 17%. Not good. This is a guide that ultimately I would offer to support screening. I offer these last data points because it's going to be important for us to orient to the need right now. Screening was important before the pandemic. It's incredibly important right now. So I guess like I've got all kinds of resources for you to steal in here. This is the video that I talked about that kind of marches you through receiving that data and readying up the spreadsheet such that it's ready for review with your mental health staff. These are progress monitoring templates. Let me show you these real quick. These are cool. If you're engaging in progress monitoring, or maybe you use a GAD, right? And you find a bunch of students that you enroll in services, but you need something to progress monitor. Well, make a copy of this for your kid as they enroll in services. They fill this out at the beginning of the session, like any good CBT practitioner. You are doing your mood check at the outset of the session. You're having them fill this out. This guides session agenda creation, and over time produces a very pretty graph that you can use to show to people during meetings and stuff, and also to the kid. shows growth over time. Progress monitoring is another 2-hour conversation that we could have. And we will be having it through Thriving Minds. So stick around for that. So I guess I kind of want to end there with a big thank you to Paul and Ellie for being here, supporting. The PowerPoint is going to be sent out, Sarah, for sure. And I guess like just wanted to put out there, I'm so appreciative of the fact that you took time out of your day to learn about this practice. It is essential. If we're going to orient to kids' needs, we have to engage in this practice, and no one else is coming to the table to do this, friends. It is the onus of schools to orient to this practice and do it well. So I'll leave it there. If you have questions, I'm going to stick around till like 4:30, and thank you again for being engaged and for ultimately supporting our kids through what may be some of the toughest years of their life. So wish you all the best. I'll see you at more Thriving Minds. Okay, take care, everybody.